missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
Yay! Good evening, colleagues, and I hope you are well. I hear some of you have rain in winter, some of you have warm environment, some of us are in the middle of some cold air. But all in all I'm hoping for is that you are good and you are well and you have settled with your coffee. Maybe some of you are still cooking or you are still helping your kids with homework like myself. It's exam time. But yeah, that's who we are, health workers. We always try and make things happen. You know, we wing it as it comes. So yeah, a warm welcome to you. I am not alone today. I am with Dr. Thabiso Mufokeng. Hi, Doc. Can you hear me? Say hi at least.
Good evening, Doc, and good evening, colleagues. I hope
Yes.
I'm audible.
No, 100%, 100%. We just wanted
Thank you.
to hear your voice at this time and to officially welcome you to the Clinical Care Platform. You know, it's our third year as a platform, and we have never had a seminar in ophthalmology. We have had a talk in one of the symposiums, but not, you know, as a webinar. So we really want to appreciate you for making time, you know, to empower us in this particular field. It's a field that undergraduate, I don't want to tell you how I passed, if I've even passed. I don't know if I've passed. I don't know how I passed the eye. It was always dirty. They always said, look, and I said, I see something. Even if I didn't see anything, I just kept on saying, I see something, you know. The only thing I had mastered is the technique, which made me look as if I'm in control. But to be honest, I just didn't see anything. So I'm hoping this is a journey and we start today, but hopefully over time, you help us to love the eye and to become a little bit more confident on issues of the eye. So I'm going to just run through a couple of slides just to remind you, colleagues, and to thank you for joining us, that everything we do here at the platform is centered around improving patient care. If it doesn't improve patient care, it doesn't belong here. And to remind you as well that we are a membership-based platform. So I really want to encourage you to visit our website and consider joining our membership program so that in addition to getting the knowledge, which is probably the most important thing, we help you with the administrative things like your CPDs and certificates and dealing with the council, etc., etc. This notice is no longer relevant, but I've kept it here just so that I can remember to give you an update. And the update is we have catched up with the HPCSA. All events have been reported. If you have an outstanding CPD that doesn't show on your profile, drop us an email. We are happy to help you, but we are 100% up to date. And this coming weekend, we have a masterclass. We are going to be looking at dermatology, dermatitis, and the following weekend, it's pulmonology. I can't wait, Dr. Mufugeng, to see a masterclass there. Saying common eye conditions. That would be very nice to spend a Saturday looking at the eye. So yeah, we are excited about that. And yes, colleagues, again, don't forget, I'll share the link later just to remind you, don't miss issues of the skin coming your way this weekend. So yes, today we are looking at diabetes and the eye. And I'm so grateful for Dr. Tabiso because he reached out and said, hey, Mawela, can we collaborate? Can I bring the eye to be top of the agenda in terms of health professional education? And I can never say no to those kinds of opportunities. So we really want to appreciate you, Doc, for allowing us your time to empower us. But let me introduce Dr. Tabiso fully because this is the first time we host him. He is a qualified medical practitioner since 1999. Hey, Dokotela. 1999, that's when I was starting. It was my first year medical school. Anyway, from UKZN, after that, after his community service, he spent 8 months as a registrar in orthopedics. One day I must interview you about your journey because now what's the relationship between the bone and the eye? But it's for another day, colleagues. So he joined the vet second in ophthalmology as a registrar in 2018 and he completed in 2022. And his research at the time, a case report was published in 2020 in the International Ophthalmology Conference, and also the MMed research also published in 2023 edition of the South African Ophthalmology Journal, and also an official journal of the Ophthalmological Society of South Africa. So currently he is a general ophthalmologist in the private sector at SafeSight Cataract and Eye Laser Center, which is based in the Morningside area in Sandton. Doc, I wish I had time. I was going to ask you a lot of questions about your journey. I have an interest. You know why? Because many people feel stuck. Many people feel like they always have to make the right decision to be successful in life. But me and you, we know that it's a meandering journey. Yeah, you can share your slides in the meantime. Find that green button. I hope it's easy to find. Yay, it's coming, it's coming, it's coming. Bulebuyek says, what an encouraging journey from bone. Yeah, from a hard bone to a soft eye. Who's that? Pellegrin. Okay, Doc, can I hand over to you? You can put your slides on a slideshow and then take us from here. Thank you.
Thank you, Dr. Mawela, for a gracious introduction. And yeah, and thank you again for the opportunity to allow me to discuss this topic in general diabetes and the eye. I feel that diabetes is one of the oldest disease known to modern medicine, but we still have people losing vision secondary to diabetic complications. And I just thought maybe let's start a campaign by talking amongst ourselves as colleagues, and then we'll take it further with time. So without much further ado, my talk basically is going to be broken down into these few topics, but I'll just do a basic introduction of diabetes and its complications to the eye. And then I'm going to go straight and focus on what we call diabetic retinopathy, because it's the most common complication and unfortunately the most devastating of them all. And we'll obviously have a look at the risk factors. Risk factors are obviously important when you want to prevent the event, like the old saying, the old addendum that prevention rather than cure. We're going to look at risk factors, and after that, I'm going to have a short discussion in a form of slides of abnormalities that cause vision loss from this diabetic retinopathy, and then we'll go to the prevention and treatment. And then I'll just conclude by presenting two case reports from the practice, two of the patients that I've seen a couple of years back. So diabetes mellitus, as we all know, it's a growing epidemic, and it's a major concern for healthcare systems globally. Coming to the ophthalmic complications, I just tried to break them down into common, uncommon, and rare. So the most common, as I've already mentioned, is diabetic retinopathy. So diabetic retinopathy as an entity, it's graded, whereby like we start talking about background diabetic retinopathy, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. And amongst all its grades, macular edema can be a feature, and that's why I also have to mention it as under diabetic retinopathy. Other common complications are iris atrophies, whereby like patients present with disabling photophobia from this multiple iris atrophies. And the other one, it was mentioned as uncommon, but I thought I must put it under common because it's actually important. Unstable refraction, where it happens that the patient, especially those type 2 diabetics, who, because it's an insidious long-term disease, we find that the patient's prescription for his glasses, it changes. And with that, they get new spectacles, or if ever, let's say they were seen by an ophthalmologist, they undergo LASIK, where we try to correct the refractive error. But you find that if the patient was diabetic and unaware, that glycemic state will will increase the refractive error, especially if it's hyperglycemia, they'll get like the hypermetropia increases. So, that's what we call, when you say a person is farsighted, we call it hypermetropia. If you correct that, and a patient goes through expensive intervention through that, 6 months down the line, 4 months down the line, when the diabetes is stable, the script is going to revert back to a much lesser script. And now, whatever you've done will actually be kind of a disservice to a patient. Other uncommon complications from diabetes, accelerated age-related cataract. I'm mentioning this because we know cataract is an aging process, but in diabetics, it can present early. I mean, we get 40-year-olds having like mature cataracts, and when you check, it's found that the person has been diabetic since the age of 15, 20. So it's just important to note that they can have accelerated age-related cataract at a younger age. Recurrent styes, xanthelasma, neovascular glaucoma. This I'm also going to discuss it when we talk about basically the severe form of diabetic retinopathy. And sometimes patients can have ocular motor nerve palsies. So by that, we're talking about things like your third nerve palsy, your fourth nerve palsy, or even your fourth, or, so basically, those are the nerves that supply the eye muscles. So that's why I'm mentioning those. For example, a third nerve palsy, we usually divide it into surgical and non-surgical. So if it's due to things like diabetes or hypertension, those are the microvasculopathies, it forms under non-surgical. It's not very common, but it's always important to keep it in mind. A patient will come, we used to say the eye will look down and out with ptosis if a patient has a third nerve palsy. It's important to also rule out that it could be from long-term diabetes. Reduced corneal nerve sensitivity. This, I won't lie, I haven't seen much of it. Usually, reduced corneal nerve sensitivity, we find it with infections in the eye, like herpes zoster and that. But it's mentioned there, and I guess it's part of the path, the disease itself, affecting the nerve supply in the cornea. And this could also be very important because patients can have corneal ulcers unaware because they've got loss of sensation. And then other rare diabetes complications are things like your papillopathy, where patients will present with a swollen optic nerve and leaking vessels from the optic nerve itself, light near dissociation. This we see it a lot with neurosyphilis, but it's mentioned as well as under diabetes. I wasn't aware of that, I must say. Optic atrophy and multiple neurological abnormalities will be obviously part of very rare complications of diabetes. Rhino-orbital mucormycosis. This is extremely rare. I've only seen it once. It's fatal, unfortunately. Most patients, when you see them, like the patient that I remember when I was in the registrar, he was actually in ICU and they actually demised because it's a very, very bad disease. So it can also affect the orbit coming from the sinuses and it spreads there. And the management is like very destructive to say the least. Now, coming to the chunk of what I think it's most important is talking about the diabetic retinopathy. So its prevalence is that it's one of the leading causes of vision loss worldwide. According to American Academy, it presents it's more prevalent in the age group of 25 to 74 years. So you can see it's quite a wide range, age range, and we need to be able to catch this patient before they even develop this diabetic retinopathy. And among patients with diabetes, 40% of them, which is more common in type 1, will have diabetic retinopathy. And of those, 10% will have severe, like a sight-threatening disease. So yeah, I think that's it's quite scary if you think about it. And patients with type 1 diabetes mellitus, at diagnosis, usually they don't have any form of diabetic retinopathy. But at 5 years, 25% will have some form of background diabetic retinopathy, whereby, this is not sight-threatening, and it's important just to note it so that you can follow up the patients because it's like it has its own natural history from being just a background diabetic retinopathy to being proliferative diabetic retinopathy. But this is rare in the first 5 years in patients with type 1. And I must just apologize because in ophthalmology we use a lot of acronyms, but I'll explain them as I say them. Like PDR is proliferative diabetic retinopathy. So at 20 years, patients with type 1, 98%, it's almost all of them basically, will have some form of background diabetic retinopathy. So what's important to note is that these patients don't have any complaints because it's not vision threatening. But now they are walking around not aware that it's a ticking time bomb, things have started. And if people are not aware, they don't take means to obviously prevent the worsening of what is already starting. And then at 30 years, 98% will have some form of proliferative diabetic retinopathy. So proliferative diabetic retinopathy itself, we also grade it. There's still that mild form, which is light to moderate form, but there's also the endpoint where we have the high risk proliferative diabetic retinopathy. That's devastating, even to the treating clinician. We don't like to see patients at that level of the disease, but unfortunately we do see them. Now, patients with type 2, the literature splits them into insulin dependent and those who are not on insulin. I know physicians don't use this classification anymore of insulin dependent and non-insulin dependent, but this is specifically just to say that those who are type 2 but who need insulin, at diagnosis, 30% of them will have some form of background diabetic retinopathy. And by 5 years, 40% will have background diabetic retinopathy. And only a small percent will have some form of proliferative diabetic retinopathy. And then at 20 years, 90% will have some form of early changes of background diabetic retinopathy. and at 25% will have the severe form of the disease itself, as like proliferative diabetic retinopathy, and 40% will have what you call clinically significant macular edema. So this macular edema on its own, it's very it can be vision threatening, but at least it's treatable if patients are seen on time. And then with the type 2 who are not on insulin, a fewer percentage will have background diabetic retinopathy. That is 20%. At 5 years, only 30% will have background diabetic retinopathy, and 2% will have that. But then at 20 years, 50% will have some form of the background diabetic retinopathy, and only 10% will have the severe form. Now, why I'm mentioning this is important in terms of our screening protocol. So basically, a patient who's type 1, we can start screening them at 5 years onwards. But a patient who's type 2, because of the natural history of type 2 patients itself, because it's an insidious process, it's gradual, it's chronic, a patient might not be aware that they're diabetic. By the time that they present to you, there is some form of problem. So anyone with newly diagnosed type 2, they need some form of ophthalmology assessment to exclude devastating sequelae of diabetic retinopathy. Now, when you go to the risk factors in terms of what are the variables in patients to develop a diabetic retinopathy? The main one, actually there's two main ones. Firstly, duration and poor control. But duration is the most important of the risk factors. I just mentioned here this Wisconsin epidemiology study for diabetic retinopathy because it's one of those high impact studies. I know it's obviously an American study, but it actually gives us very valuable lessons. That after 20 years of having diabetes, 99% of type 1 and 60% of type 2 demonstrated some form of diabetic retinopathy. And those with type 1, 50% at 20 years will have proliferative diabetic retinopathy. So this is very, very crucial because now it just shows us that the longer the duration one is diabetic, especially with type 2, even with type 1, the more we expect to see the natural course going towards the sinister side of basically having proliferative diabetic retinopathy. And it's important to note this because there are interventions, but then there's a time where like those interventions don't do much if a person comes for the first time 30 years with the disease, 20 years with the disease. Hence, we're having this talk today. Now, after 25 years, 25% of type 2 diabetes have some form of proliferative diabetic retinopathy. So I also mentioned this finding from the US Center for Disease Control. The reason I'm mentioning this is because this other study that I'm mentioning, it's more on basically most of those patients, if not all of them, are patients from the North European descent. So basically, they are not obviously of African descent, So this the United States Center for Disease Control states that 20.7% of blacks with diabetes mellitus reported visual impairment compared to only 17.1% of white patients. And you must understand this is also done in the US where blacks are regarded as the minority. Now, I mentioned this as the last thing to say. What about our South African context? There have been a few studies, even at St. John. I mean, the one that's mentioned a lot is the one from Durban by Kara et al., where it also showed the similar patterns in terms of the duration, but it seems ethnicity also plays a role. Blacks, when they get this disease, it's usually devastating. But I'm sure more research is needed for us to see what could be the compounding factors for that. So coming to the second most important risk factor, which is us as doctors we come in, is poor control. And talking about this poor control, I will just mention two studies, and it's also important to mention this because I mean there's at least a scientific proof that these play a huge role. Now, the DCCT trial, basically that's a diabetes control complication trial. Unfortunately, that was also done in the US, where there were two questions asked, but the answers that the questions found was that intensive control, so that's the mark that weight in terms of intensive control, reduced the risk of developing diabetic retinopathy by 76%. And in those patients who already have diabetic retinopathy, it slowed the progression. So the question basically was that, does intensive control reduce the risk of developing diabetic retinopathy? And if a person already has diabetic retinopathy, does it also help? So basically the answer shows that intensive control, that's operative weight intensive control, it reduces the risk. And then the third thing that it also found was that intensive control reduced the risk of other disease modalities. It also reduced the risk of clinical nephropathy by 54% and neuropathy by 60%. So when they say clinical nephropathy, patients who will have things like, let's say, increased albumin, albuminuria, when they do those biochemical markers, those patients, if you control the diabetes, it also improved other states. I mean, and the nephropathy part is actually very crucial as well because it has been shown that, the caliber of the vessels that supply the kidneys, I'm not sure at which level, and the caliber of the vessels that supply the retina, they are of equal caliber. And hence, any patient who demonstrates some form of diabetic retinopathy, there's a 95% concordance chance that he or she has some form of nephropathy. And mind you, the nephrologist, for them to confirm this, they have to do an invasive procedure where they do kidney biopsies. So doing a fundus exam in a diabetic who's probably suspected to be having some form of nephropathy, and you find that they don't have diabetic retinopathy, even when you do ancillary tests, like, we do other scans like your OCT, and it excludes that. That can save a person from having what is obviously an invasive procedure. And yeah, so basically, this just says, as treating doctors, we shouldn't work in silo, we should actually be communicating amongst ourselves and for the better outcome of our patients. I must also emphasize that, we are the custodians of our patients' health. They trust us, and it's important for us to note such things. Now, another study that was done in the UK prospective diabetic study. Basically, this one looked at type 2 diabetics. And the questions that they were asking basically was to find out if ever we have intensive control of blood glucose level, will it slow the progression of diabetic retinopathy? And it proved that it does. It reduces the risk, and it also reduces the risk of other microvascular complications. The next thing that they had looked at was to look at the intensive control of blood pressure. And it also showed that if a patient with diabetes, I mean, most of these, they go together, and you control the diabetes, but you also have an intensive control of the blood pressure, it slowed the progression of diabetic retinopathy, and it also reduced the risk of other complications of diabetes, basically things like your nephropathy or neuropathies, and etc. Now, the take-home message for me from these two studies that I mentioned, like I said, the operational weight here will be intensive control. Intensive control is associated with decrease in diabetic retinopathy onset and progression if patients already have some form of diabetic retinopathy. And secondly, it also reduces the need for ocular surgery. I just wrote that thing as a side, metabolic memory phenomenon. It's actually something that I came across for the first time as well. So basically, it also found that patients who had early intensive control of their glycemic state, 20 years after having good initial intensive control, even if their HbA1c changed a bit, they still didn't need, there was still a reduced rate for ocular surgery. So I guess it's also important that we catch these patients early and we treat them up, we control the glucose strictly basically until we are sure that the person is obviously well controlled with that regard. And then it also found that the HbA1c of less than 7%, it's basically it's a recommendation they made that, I mean, if HbA1c is less than 7%, most patients with diabetes mellitus won't progress to diabetic retinopathy. But I know that the physicians actually prefer it lower than that. I think they say 6.5%. So pregnancy is one of also the risk factors for diabetic retinopathy. It's not necessarily one of the common ones, but I just thought I should put it and elaborate on it because pregnancy alone is associated with rapid progression of pre-existing diabetic retinopathy. It's also important to know that it's pre-existing diabetic retinopathy. So patients who are pregnant and they're diabetic, but they don't have any diabetic retinopathy, they're not necessarily exposed to having diabetic retinopathy. But of course, they need to be at least have some form of baseline assessment during the first trimester. Now, I just mentioned a few reports which were done on studies for pregnant women. So the first report, it found that only 10% of pregnant diabetics will develop some form of proliferative diabetic retinopathy. And only less than 0.2% will progress to proliferative diabetic retinopathy. So, which is coming to what I've already mentioned, that a single baseline ophthalmology assessment in the first trimester is usually adequate, unless the patient reports some changes in their vision, specifically. So, I mean, pregnant women go through a whole of many other things. So it's not necessary for us to be overwhelming them with regular visits if they didn't have any pre-existing diabetic retinopathy. And then the second report, it looked at patients with non-proliferative diabetic retinopathy. So that's a milder form of a diabetic retinopathy. Usually these patients very rarely will need treatment. But 50% of them who demonstrated some form of non-proliferative diabetic retinopathy showed progression of their non-proliferative disease. And about 5 to 20% progressed to the severe form, as in the proliferative diabetic retinopathy. And the rest regressed to mild disease by the third trimester. And then the third report, where it looked at patients who already have existing proliferative diabetic retinopathy, it will worsen in about 45% of these patients. And the progression reduced by 50% with no recurrence reported throughout the pregnancy in those patients who received treatment. And I will discuss that when I talk about the treatment of proliferative diabetic retinopathy. But patients with PDR, the first line of treatment, we do what you call R1PRP laser. So if these patients receive treatment, it will definitely help with the disease being treated. There won't be any progression. I mean 50% reduction, sorry. So the last report, it looked at patients who are pregnant, diabetic, and who have macular, whereby they look at them in terms of macular edema. And it's found that pregnancy on its own is kind of a risk factor for patients to develop macular edema. Or it can even worsen if it was already present pre-pregnancy. And linked to pregnant diabetic women who have So yes, basically the macular edema is linked to patients who already have proteinuria and hypertension. Oh, sorry, let me move back to the slide. And then most studies reported spontaneous resolution of macular edema after delivery. So what this report is just telling us that one should not be in a hurry to treat macular edema specifically. And unfortunately, at the moment, I'm not aware of any major study that reports on the benefits of treatment of macular edema in pregnancy. So now the analysis from this study of patients with, diabetic pregnant patients, it obviously showed us the predicating factors. That if we have greater pre-pregnancy severity of diabetic retinopathy, that's like a poor prognosis. I mean, that in terms of a progression. If you have poor pre-pregnancy control of the diabetes mellitus, and if you have, okay, this one is actually interesting. If ever a person who's pregnant and hyperglycemic, if there was a rapid control, whereby like the glucose was dropped too rapidly, it can actually work in the opposite. I don't know the pathogenesis of how that happens, but it's mentioned. So I guess these are important for obviously our colleagues who deal with pregnant pregnant patients. But I think it's important to note that you don't want a pregnant patient to, in the process, lose their sight as well. Now, the risk of progression is related to the severity of diabetic retinopathy in the first trimester. And then our frequency of reviews should reflect individual risk. So, I mean, if a patient it doesn't have diabetic retinopathy, basically in the first trimester, we know that chances are they'll be on the safe side. And then early intervention, like I said, we do PRP laser, is recommended either before pregnancy. I mean, that's if a patient will tell you that I'm planning to fall pregnant and they've got severe diabetic retinopathy, or in the early trimester in patients with a severe disease. So proliferative diabetic retinopathy, it may regress without treatment if it occurs in the third trimester, if it occurs late in the pregnancy. And then in those patients, or in those patients who develop the PDR after the first trimester, basically. So patients with macular edema can be observed, and the majority of them will resolve spontaneously. So there won't be a need to do some form of intervention as long as you note it. And it's important to also know that gestational diabetes is not a risk factor for diabetic retinopathy. If a patient never had diabetes pre-pregnancy, it's not necessarily an indication for them to come for laborious ophthalmic assessment. Intrapartum glycemic control is the best indicator of the fetal well-being than the grade of the diabetic retinopathy. So even if a patient has an extensive proliferative diabetic retinopathy, it's important that the management of the glycemic state is up to standard, basically. And then other risk factors, I mean, hypertension, I've already mentioned it. Which is common in the type 2 diabetics, and it should be vigorously controlled. They recommend that at least it should be less than 140/80. Nephropathy. So patients with severe kidney disease, they're associated with the worsening of the diabetic retinopathy. And it's mentioned that adequate treatment, like let's say maybe kidney transplant, in those patients that warrant that, it actually also helps with improving the diabetic retinopathy, and it also helps with improving the response to the intervention of treating the diabetic retinopathy. Hyperlipidemia, it's also one of the risk factors, and there's studies that show that a positive effect on slowing progression of the diabetic retinopathy in patients who are taking statins. And the statins may also reduce the risk of developing macular edema. Actually, we have got people whereby like any patient who's diabetic, and even if they've got a borderline or normal lipid profile, it causes no harm to start them on a very low dose of statins. I think it's actually to their benefit. And then other risk factors that I mentioned are things like obesity. I think that we all know, smoking, cataract surgery. Actually, cataract surgery, unfortunately, in diabetics, it can be a predisposing factor, especially for the macular edema post-cataract surgery. So now the abnormalities that are associated with the loss of vision from diabetic retinopathy. So the first one being a capillary leakage, basically the diabetic macular edema. I'll just show a few slides of that, and the next one will be the patients, obviously, with that they can have capillary occlusion, and then with that they can have macular ischemia. And the sequelae of the ischemia, of course, we have abnormal vessels developing, neovascularization. They can get vitreous hemorrhages, they get retinal detachment and neovascular glaucoma. So these are just, actually, this is one of my patients. Just for me to show, this is an OCT. So the first frame on your left, it's a fairly normal macular OCT. We're looking at the retina. So
Hi,
the
Doc.
first slide, sorry.
Yes, do mention what OCT is. Thanks.
Thank thank you. So OCT is one of investigating modalities that we use in ophthalmology. So it stands for ocular coherence tomogram. Because we don't have the luxury of doing retina biopsies. So they say OCT is the closest to giving us what histology will show you. So the picture on your left, it has two photos. So the one photo you'll see there's what are supposed to be vessels, that brown like wiring things there. Those are arcades coming from the optic disc, that black part. And then this is just a cross section showing us the layers of the retina. Where you find the dip, that's what you call the fovea, which is the center of the, which is central. It's centrally placed in your macula. So for us to have sharp crisp vision, the fovea is the most important part of that. Now, if a patient develops macular edema, like if you look at the screen on your right,
Yeah.
that dip.
Yes, Doc, there's a
Right.
request that you must point. Thanks for that.
Yeah,
with your
actually,
mouse.
as I'm
We can see it. We can see it with your mouse.
oh, you can see.
Yeah, if you
Oh,
can use your
thank you,
mouse.
guys.
Perfect.
I'm very
Yeah.
sorry. I'm very sorry. Okay, let me start again now.
Yeah.
So the frame on your left, this is the cross section of the retina. So it's like a tissue cut, and the person is looking at it on a slide. But of course, with this, we're seeing it with our OCT machine. So this is how a normal retina should be looking like. Now, the picture on your right, where there's now leakage and macular edema, that dip is gone. One of my patients calls it the valley. Now you have a hill there. Yeah. Are we good, Doc?
Yes, you've got even positive comments on that. Thanks, Doc.
Okay. All right. Sorry about that, and thanks for pointing that out. Okay, so that's one of the reasons, that's one of the causes that can make a person to lose vision. But interestingly, if the person gets treatment, the vision becomes restored with macular edema. Now I also spoke about macular ischemia. So this is a fundus photo of the right eye. So gosh, I think I should connect this to a mouse because I'm okay. Let's see. I keep losing my arrow. But anyway, if you look next to that disc there, just lateral to it, the retina should look pink. That's a healthy retina, but you can see this one looks palish. So that's ischemia from, yeah, there, it looks palish. So that's ischemia. And then and unfortunately with ischemia, what's going to happen next is that the patient is going, I mean, the body is going to say, you know what, we need more blood supply, and then you get
New
abnormal
vessel.
vessels developing, and the disease just goes south from here. So this is another this is another screen of just basically demonstrating ischemia. And then if you look, gosh, I keep, uh, yeah. So this arrow here, actually, that's already pointed there. That's just showing us a sclerosed vessel, a vessel that's already occluded. And obviously, if the vessel is occluded, what's going to happen? That area is going to undergo ischemia. You know, it's gonna go ischemia. And so this is just a fundus photo, but it's also already showing us the abnormal vessels developing. These are like shunts developing. So this is already what you call PDR, and it's like moderate to severe when it's already at this level. Now, on this other side, this is just basically what you call fluorescence angiogram. When we put fluorescence in your bloodstream just to locate where the occlusion is, but it also shows us when you want to measure the amount of necrosis. So this is already, you're seeing that that area is already kind of necrotic or ischemic, just use the right word, yes. Peripheral to the obliterated vessel. Nice. I think on this frame, I just wanted to show patients with neovascularization, where like you have abnormal vessels developing, and gosh, and with those abnormal vessels developing, you end up having retinal hemorrhages. So this is some form of proliferative diabetic retinopathy as well. And it's obviously the one that we say it falling under severe form of the diabetic retinopathy. So patients also get what you call vitreous hemorrhage. Now, this one, it's a vitreous hemorrhage, but you see it has a particular pattern. We call it, it's boat-shaped. So it's a subhyaloid hemorrhage. So they bleed from these abnormal vessels. And this subhyaloid hemorrhage, commonly, it will be right in front of the macula. And it's usually sight-threatening. And usually most of these patients, they'll end up in theater because they'll need what you call a PPV, but I'll come to that as well. So this is another frame just showing us a vitreous hemorrhage, which is just in, my pointer is, yeah. So yeah, basically on your right there, you can see that exaggerated bleed. It's what we call periretinal hemorrhages, and it's obviously part of the vitreous hemorrhages. The severe form of the disease, patients will develop what you call tractional retinal detachment. Now, yeah.
Hi,
So as you
Doc.
can see, there's yes.
Let's try to get the PowerPoint, what you call pointer. So
You know what I can
if
do?
you move on your
Can I point?
left lower corner, if you move your mouse towards your left lower corner, where there was these buttons for moving your slides, I want to show you how to pick up a pointer. Just
You know what, Doc?
yeah.
I was actually not using a mouse. Let me connect the mouse and see, because I was just using.
Oh,
Yeah,
okay.
let
I
me
wanted to
see.
show you the better way to select the pointer. Click anywhere on.
Yeah, yeah. I'm
Yeah.
just worried about the time.
Oh, okay.
Yeah,
Okay, no,
so
it's fine. Yeah.
yeah, I think
All right, sure.
yes. Hey, guys, excuse me. I'm very sorry. I'll get it better next time. So yeah, so this is the split. This is the neurosensory retina. This
Okay.
is the part of the lower part of the retina. So this is an OCT picture of end-stage diabetic retinopathy. This is the patient that I saw recently after she was seen in 2021 and unfortunately disappeared. And now this is the end stage of the disease, where we can still intervene, but the prognosis is really guarded. But I just wanted to show you those frames. Now we've got a mouse. I think the next pictures will go in smoothly.
Awesome.
So this is neovascular glaucoma. So how do we get to see neovascular glaucoma? We have iris vessels. So any normal iris is not supposed to be having vessels like this. So we usually count them in clock hours. So you can see, you can see this is at least 8 clock hours, And with these vessels here, they also develop vessels in the angle, those abnormal vessels. And usually that gives us what we call neovascular glaucoma. And it's part of an end stage of proliferative diabetic retinopathy. It's actually regarded as advanced proliferative diabetic retinopathy. And the prognosis here is really, really guarded because now they end up with a very raised intraocular pressure. That's very difficult to control. And if they have vessels here, you can imagine the back of the eye. It means it's vessels almost everywhere. Now, how can we prevent diabetic retinopathy? I think it's crystal clear. Intensive glycemic control is the top one, and this is done by us, clinicians, basically, with the first line, the people who see these patients, because if we have this well controlled, already all those sinister pictures that I've shown you, we prevent that. Intensive control of blood pressure. And I must say that these two, it's only not us, the clinicians, who are responsible. The patients are also responsible. I always say it's a team effort. The coach can do the best they can do, but if the player is not listening to the coach, it's a problem. And intake of statins, it's been proven. There's a few studies. Lifestyle modification, smoking, drinking, or should I say moderate drinking at least. And then early involvement of other disciplines. For example, young females, when they start saying, I want to plan falling pregnant and they're diabetic, it should start there. Young children, like, the type 1s, whereby like a child has been diabetic from the age of 8, 9. By the time they hit puberty, it's associated with extreme rapid progression from just non-proliferative to proliferative. So you don't want to miss this window period. And hence, that's why I'm saying the screening guidelines should be emphasized to our patients. Like, for example, a type 2, they should be screened appropriately on time, type 1, when you should start screening them. And already I've mentioned the prevalence. We know that, and those risk factors in terms of the duration. Now, I'm going to touch on the treatment, but I felt before I go on treatment, it's just to remind our colleagues about the basic anatomy of the retina. The inner layer, we call it the neurosensory retina. And then beneath this one that is hyperreflective, we call it the retinal pigment epithelium. So these two, they have different functions. But of course, the neurosensory retina is the crucial part for us to be able to perceive vision. And with that, obviously, we also go to the retinal vasculature. So from the optic disc, the central artery divides into those arcades, superior and inferior arcades. It divides into 4, basically. And then these vasculations, of course, from there you get arterioles and up to capillaries. And the capillary plexus, actually, it's in 2 forms. We have the inner one, which is more around, it's in the, they say it's in the nerve. It's in the ganglion nerve layer. So it's in some part of the neurosensory retina. And then there's the outer capillary plexus as well. So both those capillary plexuses, they actually come from directly from the central retinal artery, and they supply 2/3 of the retina. So I think the other one, the chorocapillaries, I don't need to mention much. What's important is the capillary plexuses that is coming from the central retinal artery. And now coming to the pathogenesis, it's complex, but there's certain hypothesis. For example, the extended exposure to hypoglycemia itself, that it stimulates production of a whole lot of inflammatory markers, your oxidative stress, your protein C kinase, and a few other ones. And then these inflammatory and that biochemical imbalance on its own, it actually destroys the endothelium and also destroys the pericyte. So pericyte is part of the I would say the layers of the capillary wall. And secondly, microvascular occlusion. So the reason I'm mentioning this, because when I talk about treatment, you'll be able to follow that this treatment is basically trying to intercept this part of the pathogenesis. So microvascular occlusion and leakage, I mean, that I suppose it obviously makes it kind of sense. But then what causes this occlusion, microvascular occlusion? There are some hematological changes. Like, your red blood cells, they become abnormal. They cause that Roulet effect. And then you have capillary changes where the capillary wall itself, you have endothelium thickening and loss of your smooth muscle, and that on its own, it promotes the occlusion. And then once we have the occlusion, what will happen? There won't be enough blood supply. You get hypoxia. Hypoxia, the tissue gets ischemic. Now, once we reach this part, what happens? We have an increase in angiogenic factors. So basically, these are things that stimulate development of vessels, but basically these will be abnormal vessels. And the main angiogenic factor that has been studied, we call it vascular endothelial growth factor A. So our treatment targets this angiogenic, vascular endothelial growth factor A. But there's many others that are coming, that there's a lot of research that's going through about other forms of VEGF except A. Now, once we have the stimulation of these angiogenic factors, we have abnormal vessels developing, arteriovenous shunting. And then when that occurs, basically there's a shunting between the arterioles and the venules. And in between that space, there's areas that are not having blood supply at all. And that's obviously promoting to like necrosis of the retina. Now we have this new vascularization. I've already mentioned that as well, AV shunting, and that because of the stimulation of the vascular endothelial growth factor A. Macular edema, so this is cystoid macular edema. So macular edema is obviously due to the extensive capillary leakage, and then because these vessels are obviously abnormal, so they leak very easily, and then they cause that heel that I was mentioning earlier on. Now, how do we treat diabetic retinopathy? Macular edema, as I've already mentioned, it can happen in any stage of the disease. And we have treatment that works. We give them what you call intravitreal anti-VEGF, anti-vascular endothelial growth factor. So I'll just say anti-VEGF. It's the first line of treatment for macular edema, and patients respond very well. But now, some patients might not respond to the first line treatment. We go to the second option, intravitreal steroids. I just mentioned two that are commonly used. And as I already mentioned in the pathogenesis, we have increased inflammatory markers. It's not surprising why some patients, they won't respond to anti-VEGF, but they'll respond to steroids. Actually, some patients, they'll even go on to respond to a combination of two, but that will be another discussion for another day. And then some patients, but this is, I must say, it's no longer used when we do a focal PRP, especially if ever the patient has a focal macular edema. But if they've got a diffuse macular edema, we use grid PRP. But as I'm saying, this is no longer the practice because anti-VEGF has really changed the management of these patients to a far much better outcome. Because this PRP is laser, so it's also destructive to the tissue as well. And then non-proliferative diabetic retinopathy, most of these patients, they won't need treatment unless they've got non-proliferative diabetic retinopathy together with diabetic macular edema. So once they have those two, then they'll also benefit from intravitreal anti-VEGF, you know. And then we can also use it for patients with very severe or very severe form of the non-proliferative diabetic retinopathy. Because I won't go into the stages in terms of what do we look for to say this is severe, this is not severe. But I just think for the purpose of the discussion, it's important to know that the earlier we get with the disease history, the better. Now, what do we do for patients with proliferative diabetic retinopathy? The first line of treatment is still PRP laser. How does this laser work in terms of what does it do to the eye? Basically, it ablates these abnormal vessels that are supplying the necrotic tissue. And for some reason, when we do that, it can actually more often than not, it will regress as if we pick it up in time. But anti-VEGF, it's still a safer alternative to first-line treatment. And the nice thing about anti-VEGF as well is that it actually works quicker than PRP laser. I mean, within a week, you expect to see changes when you repeat your OCT scans in these patients, or when you basically examine them. Within a week, you expect to see some form of changes. And then there's also a lot of room for using both anti-VEGF and laser, especially in patients who have this severe proliferative diabetic retinopathy together with macular edema. But in some patients, we might have to go in where we call it the PPV, a pars planar vitrectomy. So these obviously everybody will refer them to our vitreoretinal surgeons. And obviously they also don't like treating this end stage disease because the prognosis is really guarded. But I mean, when is it indicated? If a patient has extensive vitreous hemorrhage, or if a patient has bilateral dense vitreous hemorrhage, if the patient is not responding to the PRP, if it's an only eye, let's say one eye is blind, you really want to obviously be slightly more aggressive. Now, I've already been mentioning vitreous hemorrhage, so I thought I must also talk about how we manage vitreous hemorrhage. So there's this study called the Diabetic Retinopathy Vitrectomy Study. What it looked at is that type 1 diabetes mellitus with severe vitreous hemorrhage, they showed benefit from earlier vitrectomy. Type 2 with severe vitreous hemorrhage, they can be observed. You know, we can observe them monthly for 6 months. And we hope that as they control the hyperglycemia, they change their lifestyle, we hope that the vitreous hemorrhage can regress. I don't have the stats on that, but quite a few of them, they end up with a PPV after all, with basically surgical intervention. Now, what we look at when they look at the study, they also looked in terms of did the patient receive laser treatment, what you call that PRP laser treatment? If it was done, okay, let's say if not previously done, then earlier surgical intervention is recommended. But if it was previously done, you're justified to observe them as long as you see them monthly. I mean, that's very important. And in every visit, we do what you call an ultrasound. We do a B scan, this ultrasound, and then because now our things like OCT, they can't. They are not very effective if a person has a dense vitreous hemorrhage, basically, in terms of imaging as far as to show the retina. But we do the ultrasound just to exclude retinal detachment. Because on a B scan, you'll be able to see that on an ultrasound, you'll be able to see if ever there is an associated retinal detachment, and then you'll have to go in. So now, in conclusion, I'm just going to present two cases. I'm not, let me see, Tamia. I'm just going to present two patients. So let's go back there. So this is a patient who was seen for the first time in 2021. She's in her mid-70s to late 70s. So this frame here was when she first presented. And then this is of the right eye. So that right eye had hand movement vision. So the left eye, she had vitreous hemorrhage. So hence, like I was saying, we couldn't do the OCT for the right for the left eye. It couldn't be reliable. And treatment was given to her. Basically, we went all out, gave the anti-VEGF for the hemorrhage on the left eye, booked her for a pars-plana vitrectomy because she's got tracheal retinal detachment. If you remember, I did mention the indications for surgery. If there is a retinal detachment, we have to go in. Unfortunately, this lady in 2021, the history was that she's been diabetic for 30 years. She disappeared. She never came back. And I must also add that on the day when she presented, that right eye had some form of vision, even though it was like count fingers, but that's better than nothing. And on the left eye, she had only light perception. So she was booked for open surgery for both eyes, and she never came. I saw her in January this year. Gosh, I don't know if I'm trigger happy here. So I saw her in January this year, and unfortunately now, one eye is completely blind. The other eye, we did a cataract procedure for her. And when you look at the back of the eye, this is after cataract surgery, because on the day when she came, we couldn't scan her in any way because the eye was in bad shape. So we really couldn't get any imaging from her. So going back to this patient here. Now the retina, if you can see, you cannot even see much of it compared to on this scan that she came in 2021. So that's why I'm saying sometimes education from us, even myself included, to say to emphasize to the patient that this is important. If there's issues with funds or whatever, here's a referral letter, but you need to. But we still have colleagues in the public sector where like you can say I can make a phone call to arrange to say can this patient be seen urgently, because it's not nice for a person to lose vision, like I say, from something that can be somehow salvaged. But I think in her case, it was already towards the end of the disease. Now, this is my second case. This gentleman is a 56-year-old patient. 2023, June, he underwent cataract surgery in both eyes. Come September, on our follow-ups, he's a diabetic, by the way. Post-cataract procedure, everything was fine. We were happy. Visual acuity was 6.6, 6.7, on the right and the left. So that's like a good outcome. But 3 months later, she developed, I'm sorry, this scan here is not the same as the others, but this is our retina. The dip is gone. There's a hill, so there's a leakage. And he was unfortunate. He developed on both the right and the left eye, But then we went to our anti-VEGF treatment. We gave her the injection. He came back a month later. And by the way, these procedures are office procedures. These intravitreal injections, these PRP lasers, they are office procedures. And we just make patients to be comfortable, and pain is definitely not a big issue. So this is a month post the first injection. This is now in October. As you can see, the right eye, the dip is back. Mr. V is happy. The vision has gone back from being 6.8, it's now 6.9, 6.6. And unfortunately, the counterpart, the left eye, the heals is still persisting. So the teaching tells us that, you gave anti-VEGF already, but the right eye improved. Let me give another anti-VEGF and see what will happen. So we do another anti-VEGF for the left eye only now, because the right eye we know it has resolved. Now on the right eye, we can see the dip is still there. This is another modality whereby like we like showing it to patients to show them that there's progression, there's improvement or what. But in the left eye, the heel is still there, even though there is that green color. So when you see green, it's basically showing us that it is going down, But it's 2 injections, still no improvement. What did I do? I go to the second line. So we gave this patient intravitreal triamcinolone. We gave him a steroid. And it was multiple steroids, I must say. Probably gave him one full cycle. So a full cycle is like 3 injections. And steroids, instead of anti-VEGF, we give them every 6 weeks. Anti-VEGF, we give it every 4 weeks. Now, the last time I saw this gentleman last year, this is where we were. When we started the treatment, this is where we are. So now the retina is normal, the macular edema is gone. And the green is showing us that it has gone down by quite significant. Basically, we were both happy. Me and the patients were happy. Me and the patient were happy. And yeah, I think I'll stop there, but then just say maybe in conclusion, it's crystal clear that early intervention, I guess like with any other disease, is very crucial. But patients really get what we call irreversible vision loss from something that shouldn't be happening. I know there's other bigger problems. There's financial issues. Patients sometimes they don't even have taxi fare to go to the hospital. But I think we need to emphasize to our patients that we want them to keep on having crystal clear vision. Doc, I think I'll end it there.
Awesome, colleagues. Let's give my dearest Doc Mofokeng all assorted thumbs and hugs and everything. From me, you get the horn, Doc. Vuvuzela.
Thank you, thank you, thank you.
It's yours. Yeah, I mean that was very, very, very awesome and empowering. So I really, really want to thank you for that. We have a lot of questions to go through. So yeah, I think let's get ready for that. You can stop sharing, Doc, from your side if you are able to, so that the colleagues
I'm able to. Thank you.
yeah, so that colleagues can see you. Yeah, there we go. There we go. Colleagues, obviously, there's like before he even finished, there was already 30 questions or something like that, 14 questions or whatever. So let's go and see how far we go. I had my own questions, but I think let's stick with what the colleagues are saying, and then I can chip my questions if time allows. So Angie was
Thank
asking
you.
there, are you saying those who are insulin dependent are more at risk of proliferative disease compared to the non-insulin dependent patients? And maybe the key question from Angie is, why would that be the case? Yeah.
Okay. Thank you, Angie. So basically, the patients who are like the type 2, who are non-insulin dependent, we screen them earlier because of, by the time we see them, there might be some form of disease. But those who are insulin dependent, whether it's type 1 or type 2 or insulin dependent, it somehow follows an aggressive course. I think the reason being probably, with the type 1, that on its own is an aggressive disease, and maybe controlling it could be an issue. like we say, that the risk factor is control and the duration. But with the ones that are on insulin, who are insulin dependent, it usually follows an aggressive course to being proliferative. And I think maybe another reason as well, Angie, it could be that, with type 2, there's always an association with hypertension and this and that. And, if all those things are controlled, they don't progress much. But those who are insulin dependent, not clearly known why, but they definitely follow an aggressive course.
Awesome, Doc. Casey is interested to say, so after showing us all those treatments, which ones can the GP manage? But actually, basically, Casey is asking, what is the job of a general practitioner in diabetes retinopathy? Is it just to refer patients, or there's something else? Yeah.
Casey, I'm not sure when you joined the discussion, you are aware that actually I'm a GP at heart, because in my career path, I was a GP for longer than I've been an ophthalmologist. And the best thing, we don't want to be treating diabetic retinopathy. Let's start there. So the GPs play a crucial role in
Yeah.
adequate control. Like I said, the operational way there is intensive control of the glycemia, intensive control of the hypertension. But once let's say we follow those risk factors and they are referred appropriately, unfortunately, GP will never be, shouldn't be giving an injection to the vitreous. Unfortunately, even this PRP, we need to have one. It's one of those expensive devices, but we also have to go through the training of applying it. I think any doctor can be trained to do those procedures, because I did them when I was a medical officer, but I had to go through a training. So I could still say I was still a GP, but I was working under supervision of ophthalmologist. So if a person is doing this thing under supervision of ophthalmologist, definitely. But is it safe to do it in your rooms if you can reassure sterility? And and you underwent appropriate training. But you know what? I don't want to get into trouble with this, but I feel it's a bit of a tricky one for now.
Yeah, thanks, Doc. So Ntokozo is asking about the early warning signs, and maybe the way I'd put it, we always have these ophthalmology nurses. We don't generally have ophthalmologists. I think there's an access issue, because I think I saw there's comments about waiting periods and those kinds of things in the public sector for some of the procedures. But Ntokozo is asking, are there early warning signs of this retinopathy? That from a nursing perspective, from a primary healthcare perspective, I think you can emphasize more on prevention, but if there's any other things that can be done at that level, you can recommend, Doc. Thanks.
Unfortunately, like I was saying, a patient can have a background diabetic retinopathy and still have perfect vision. So by the time we see signs, it might not be the best time. So that's why I was emphasizing and even putting those studies down of the screening protocol, is to catch them early, to say, you know what, people have to go for screening. Because most of these patients, they'll have what we call non-proliferative diabetic retinopathy, and their vision is perfect. And hence, that's why we don't intervene. But we note it so that we know it has a natural history that you can follow if a person is not stabilized in terms of the glucose and the hypertension. So the early warning signs, no, they aren't actually.
Is that screening, which is important. And I don't know, from a
Mm.
midwife perspective, if you have a pregnant lady who had diabetes pre-pregnancy, the question is, are you referring them for eye screening checkup, Because that's what I got, at least. Because Mtokozo says, as a midwife, my understanding is that you are more worried about patients who had diabetes before they fell pregnant, and they at least need to get one eye assessment. Am I correct, Doc?
Yes, you're correct. Ntokozo is correct as well.
Yeah.
Yeah, but we know that if a person is well controlled pre-pregnancy, even though they're diabetic, chances are they will never develop diabetic retinopathy. But it's very important to at least have a baseline assessment during the early first trimester.
Okay, awesome. Some of the questions, maybe you'll make sense of them because Anonymous says fluorescence in the bloodstream or via the eye drops. I can't remember what you were
No,
talking
I know
about.
it makes sense for me. It makes
Yeah,
sense. Yeah. So, in ophthalmology, we use fluorescein a lot for different reasons.
yes.
But in this instance, the slide I was talking about, it was when I was saying if you want to assess the amount of ischemia. So we actually put fluorescein intravenously, but obviously we prepare it in a certain way for it to be safe to be given intravenously. Personally, I don't necessarily like it, but it's still an important tool because now we have advanced OCT machines with something called an OCT angio. So this is non-invasive in terms of you don't have to put a drip, but it can still give you the answers that you need. But the one that, that fluorescein will take it into the vein. And of course, whatever you put in it as an IV line, it can have side effects, but they are very rare. I mean, unnecessary side effects, even death can happen.
Awesome.
Anaphylactic reaction. Yeah.
Awesome. I think many people commented on your comment about the use of statins as part of the prevention program. And I don't know whether you are the right person to talk about the dose and how, I don't know if it's the physician's role. I mean, you only see them when there's problems, generally. I don't know, or you,
Yeah, no, no,
yeah,
no, no, no.
yeah,
But actually, I think I can have a small input.
okay.
Actually, I think my colleagues will have even more input. The slowest dose available. I'm not sure that this Aspavo is it 5. Okay, I don't necessarily mean to promote that. That's one that I'm familiar with. I think the slowest dose is it 5 milligrams, but the slowest dose available, as long as we know that this person is diabetic,
Hmm.
he has borderline lipid profile, you can start them safely on the lowest dose available. So not a
Awesome.
therapeutic dose,
Hmm.
a prophylactic dose of some sort, if I can put like that.
Yeah, awesome. So this question by Anonymous, because I was following in the chat, someone had posted that why do people who had their cataracts removed, why do they have a repeat cataract? And then someone said, no, the second one is not a repeat. It is this posterior capsule opacification. Then there was a direct question then to say, how common is this posterior? So maybe you need to comment on recurrence of cataracts and then the post capsular opacification.
Okay.
Yeah, in that
All right.
space. Yeah.
Yeah. Yeah. Okay. It's a good question actually, because patients always ask, does the cataract come back? No, it doesn't. But in almost all our patients, especially diabetics as well, you're doing a surgical procedure to the eye, the body is going to release inflammatory response. So those cells, they accumulate behind the capsule. That's why we call them posterior capsular opacities. So, people have their own protocols. For me, standard, all patients after 3 months, after they've had a cataract procedure, there will be some form of posterior capsular opacity. We just do what we call a YAG laser capsulotomy. It takes about a minute per eye. It's done, it's an office procedure. You basically break that opacity with some form of laser. And I think so what happens is that maybe patients were not being explained to. So if a patient comes to you, doc, and says, I had a cataract operation done, but it's back, it's not. It's a PCO and it can be treated. And I think with diabetics, it could be more common, but I don't have any confirmatory studies.
Awesome. Then there was a whole lot of questions when you got to treatment about availability of those treatments in the public sector. Firstly, I don't know. I wish you knew what is the rate of, I don't know, one ophthalmologist for per what population, that kind of a thing. Because there's an issue. It seems like you guys are very rare. But there's a question about availability of your treatments in the public sector. When you were at vets, at least during your registrarship, the proposed or the treatments you have shared here, are these available in the public sector? And also affordability in the private sector?
Um, I think I don't want to get into trouble with the public sector because clearly some of my colleagues are tuned in here and like, judging from the way they could answer about the PCO.
Yeah,
So it's a general problem, even not just the vet circuit hospitals. I mean, before I could get a reg post, I was in one of the smaller hospitals. I won't mention the name before I get into trouble as well. Uh, we 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 are overwhelmed. I mean, you find that. So unfortunately, I won't be able to answer the requirement in terms of one ophthalmologist per. I should be able to, but I guess I didn't look into it. But I'm supposed to be able to know that. But now that I don't write exams, I still don't read anymore. But it's important we know it. I'm saying. Get back to you guys about in terms of that ratio. But that's why we always have what you call even in our clinics we have what you call screening clinic, whereby like patients walk in, they are referred from Dr. Mofokeng from Togoza, Dr. Mawela from Zama, they are referred there. You read the referral letter, you should be able to say, you know what, this patient must be seen today. This patient must be seen within a week. This patient must be seen within a month. We do have processes. The unfortunate thing is that within those existing processes, there's loopholes. There's loopholes because at the end of the day, I mean, due to my rush time, I mean, I know sometimes you leave the clinic at 5 p.m. I mean, you're supposed to be there until 4, you know. But having said that, it's not a lie that you also have colleagues who want to be out of there before 4. So, it's also kind of a management issue as well. But I think we should be able to say this is an emergency, you know, and part of it is to also iterate amongst our colleagues to say, you know what, if this patient is type 2 diabetic and he's been diabetic for 5 years. So I think maybe the onus is also on us as the referring clinician to say, the patient of Fukeng, type 2 diabetic for 5 years, never been screened before. Please arrange for diabetic screening. And then, we've got ways of saying, okay, can I quickly assess the vision of this patient? The vision is still kind of fairly intact. No, I can see this patient within 2 months, within a month. Unfortunately, that one, it will take a while to fix it. And you're right. I mean, in hospitals, ophthalmologist department are they're regarded as a non-emergency department. So it's a bigger problem. Doc, I'm not sure if ever you can hear me. I can't hear you.
I'm busy
I couldn't
reading
hear
a
anything.
question.
Oh,
Yeah, but I was muted. Yeah, sorry. Yeah. So Exen was asking about the prognosis of progressive diabetic retinopathy, where a patient is taking equatrin and clopidogrel. I don't know if you had this in your slides, this regimen. Maybe comment on the regimen if it was there, and then if it's something that works.
I'll be honest with you. I didn't have anything about like that on the slide. But what I know is that, I mean, Ecotrim is some form of aspirin, isn't it?
Mm, mm,
Yeah. So unless if there's recent publications, so far, I mean, even according to American Academy, there's no benefit.
mm,
Patient didn't show any benefit, those who are taking aspirin.
mm,
As much as we mentioned hematologic causes, where we know that there'll be platelets causing accumulation, there'll be the relay effect from red blood cells. So basically, there'll be clots, but aspirin didn't show any benefit. I
mm.
haven't come across any study at the moment.
Okay, awesome, awesome. And then
But that's a good question, I must say.
yes, and Linda was thanking you for an awesome presentation. So these injections you are referring to, how long exactly should people get them? And yeah, and does the condition eventually heal? Do you get? But I think you had two case scenarios with good outcomes, especially your second patient, I think. But yeah, your comments. We might have lost Doc. Oh, okay.
Yeah, so basically the duration, in most of these studies, because most of these studies for treating diabetic retinopathy, actually they usually go for 2 years. Like patients are getting treatment for 2 years. but we have to use real-time studies as well. If the patient was caught early, they resolve. And if you maintain the normal glycemic state, they resolve. But you have to continuously monitor them because it can recur, you know. The treatment, like I say, if ever is patient is started treatment early, the intervention is done early, it really works. It works wonders. Now, there's newer anti-VEGF injections that are on the market. I just didn't want to go deep into that because that's a discussion that we have amongst colleagues. Commonly now we use Avastin. I'm not supposed to be necessarily promoting that, but that is what is commonly available for us. It's slightly cheaper compared to other anti-VEGFs, like there's others like aflibercept, which is almost 3 times the price of Avastin. So these injections are given monthly. Now the newer ones, from the top of my, there's one called faricimab. So this one, it really works well. I mean, they even claim that you can give it every 3 to 4 months per patient, per cycle. So one injection, 4 months. Some people even say we can even give it 6 months. Like I also mentioned, Ozurdex. Ozurdex, we can give it for at least like 6 months, 6 months cycle. The only problem is the battle with the medical aids. Oh, I don't know how many motivation letters we write and they get rejected, and you submit high impact studies, but yeah, that's a battle we are having. But that's that's obviously cost issue. So there are those that and of course, just to answer the question, for me, the regimen that I follow, I give you the injection until if it was for macular edema, until it settles. So on the last visit that I see you for the first time that edema is settled, I give you one last injection. So basically, it's like something you treat and extend, and then after that, I say I'm gonna see you every 3 4 months, and hope it doesn't recur. And if it recurs, patients usually know. They'll tell you, doc, I know my appointment is in August, but I came because I'm seeing some changes. Patients usually will tell.
I think this follow-up question or this question is important. So, because I think Babegil is actually asking when exactly should we or how often. So, let's say someone is diabetic and we're talking prevention and initial assessment by an ophthalmologist and then the follow-ups. So, when exactly, what is the preferred schedule or recommendation around that? Which patients, I don't know, how does it work?
Okay.
Yeah.
I think the first thing that you look at is looking at your risk factor. We mentioned the duration. Any type 2 diabetic, if he has never seen an ophthalmologist or anyone who can examine the fundus and determine if ever, because I mean, it doesn't have to be an ophthalmologist, as long as the services of ophthalmology in that hospital, even the medical officer will be able to assess that there's any form of diabetic retinopathy. Anyone with type 2, they need a baseline assessment. Type 1, if it's type 1, the Americans say you can wait for 5 years, but I can tell you now, in our South African context, I'd rather have them seen earlier as well, even if it's just one visit. And if it's not there, you can say, I can see every 6 months, I can see every year.
Okay, so I think that is fine. Colleagues, we're going to take the last 2 questions. We are way behind time. Where this specific channel has to transition to the Diploma Child Health colleagues. If you see me looking left and right, is because we've got the part 1 obstetrics on my left hand side, and then we have the diploma obstetrics on my right hand side. And this channel, when we finish, the child health colleagues are waiting for us. So someone is asking about the private health sector. Is Timothea, and how do you get the other disciplines to work with you? What models are you using there? Because these patients might need a podiatrist, they might need a surgeon for this, they might need a nephrologist. So the care coordination to encourage a multidisciplinary approach. Yeah.
Yeah, in private practice, okay, in the place where I work, we already have colleagues that we work close with. because some of the referrals are coming from them, some of their referrals coming from us. I mean, I found the practice existing for the past I don't know how many years now. So, but they already have system in place. But I mean, it's not like a written protocol system. But I
Hi,
just know if I need Dr.
Valerie. I think when you're ready, you should start. I'm still in another webinar. Thank you.
No worries, I'm gonna share.
Okay.
There we go.
Oh yeah. So basically, I do have a few colleagues that are on speed dial, literally.
Mm.
Anyone minds?
Okay. Okay. I think most of some of these we have already responded to. At which stage of pregnancy is it more accurate? We said if they have a pre-existing disease, we should do that. So maybe we'll take one of the questions that I had for you. You kept on referring to intense control, intense control. How do we get there? You are the Minister of Health, Doc. You have
All right.
policy
So
changing powers. So,
yeah, no, but I suppose this thing of intense control, what they were looking at was saying if a patient is type 1,
yeah.
they must start on insulin, don't play around. That's what this intensive control is. If a patient is type 2, do you say lifestyle modification first and hold the treatment, or do you start them on treatment? So intensive control, if you start them on treatment, less intensive is if you start them on lifestyle modification. And a few of patients will get it right of type 2s, or like maybe the so-called pre-diabetic. But obviously we know in our setting, for me, I won't be able to sleep at night if I say to a person, lifestyle modification first, knowing what I know now.
All right, those colleagues. I mean, I enjoyed this session. Like I said, when we opened, the eye has always been very intimidating. At least now, from a diabetes perspective, there's few things that I can start doing correctly for the patients. And Doc, we really hope to connect with you and have more sessions on the eye. I actually saw a comment. I thought I had highlighted it. Someone was saying the master class something is urgent. I can't remember who that was. I think it was when you were teaching and we were all realizing, okay, we are a bit outdated in this space. So yeah, just to say thank you very much for your time. I know what it takes to prepare, and for a specialist to still have time to prepare and come and teach us, I can never take it for granted. Your closing remarks, and then we call it a night. Thank you.
I think I just want to thank you, to thank everyone who made time to listen to me, because I mean, like you're saying, we work hard and then we come back home, we still have to work the kids, the exams. So I mean, it really is humbling for people to make time to listen to this, because it's a topic that's very close to my heart. So that's my closing remark. Otherwise, let's let's
Yeah.
let's let's take off these patients. We are their custodians when it comes to their health.
Thank you. Yeah, colleagues, that's it for the night. I've been sharing the link for membership. If you are here and you are not a member of the platform, I'd love to encourage you to join us on this journey so that we are able to continue to bring you this educational program. Just click on the link, read what we are all about. If there's an alignment between your goals for growing daily and our goals for helping you to grow daily, please join us on this journey. On that note, night, colleagues. I'm crossing over to the child health colleagues. Doc, we will catch up via WhatsApp later. Thank you. Bye, colleagues.